I'm going to turn this over to Ulrike Dydek, who is our Associate Director for the Women's Global Health Institute and will be introducing the rest of our speakers. Yes, so it is my great pleasure to introduce our keynote speaker for today, Dr. Kristina Deligiannidis. Dr. Deligiannidis is professor of psychiatry, molecular medicine, and obstetrics and gynecology at the Donald and Barbara Zucker School of Medicine and the director of Women's Behavioral Health at Zucker Hillside Hospital at Northwell Health. As director, she leads the clinical and translational research program and advises on policies and services promoting women's behavioral health at Northwell Health, which is the largest nonprofit health system in New York. As a reproductive psychiatrist, she has expertise in treating women with mood and anxiety disorders linked to the menstrual cycle, perinatal, and perimenopausal periods. Dr. Kristina Deligiannidis also is a highly accomplished researcher. She received her medical degree from the University of Massachusetts Medical School and continued there to complete her psychiatry residency and chief residency in psychopharmacology research. But even before she even started medical school, she already started training in neuroscience research at NIH. And after her residency, she completed additional research training in behavioral endocrinology and experimental therapeutics at NIH and in multimodal neuroimaging at the Martinos Center for Biomedical Imaging at MGH. Today, Dr. Deligiannidis is a nationally recognized leader in the field of perinatal depression and in novel therapeutics research. Her research program has a focus on neurosteroids and hormones, multimodal neuroimaging, and is highly funded by NIH, foundations, donors, and industry. For the past decade, she served as a principal investigator on a series of clinical trials that led to the FDA approval of 2 rapid-acting antidepressants for postpartum depression, perinatal depression. Dr. Deligiannidis has received over 30 national and local awards for her research and teaching, has published over 80 manuscripts, and has given over 100 media interviews just over the past 7 years. And with that, please join me in welcoming Dr. Deligiannidis for her lecture on scientific discoveries leading to the first FDA-approved medication for postpartum depression.
So thank you, Dr. Dydek, for the introduction. And thank you so much to the Women's Global Health Institute for the invitation. This is such an honor to come here and talk to you about really what has been personally a transformational journey as a physician scientist and my passion for women's behavioral health, especially depression during pregnancy and the postpartum period. So I always start with disclosures. For today, these are my research fundings over the past 3 years. I had a prior life at NIH, so I still do receive some funds from those inventions from the bench. And then I do serve as a consultant. I think for today, the main disclosures are that I was an investigator on all of the brexanolone and zuranolone clinical trials for postpartum depression and have occasionally throughout the year served as a consultant for that company. Everything else really I'm not going to discuss so much. And actually, if you come to the seminar tomorrow, that's what I'm going to discuss all my NIH-funded work. So although we're going to really focus on depression that occurs during pregnancy and after delivery, I wanted to start taking more of a lifespan approach. By looking at depression rates that really begin around menarche and then through menopause. I'm going to try this and it works. Great. So, we know globally that across cultures, lifetime prevalence rates, although they differ a little bit in the absolute rates, we definitely see a preponderance of depression in women versus men. And that has been consistent throughout the years. It's not a recent phenomenon. But we do know that overall, we're seeing about a 2 to 3 times more likely prevalence rate in women compared to men across their lifetime. And as you can see, there's a divergence of when these things take off. And so you'll see in purple for individuals with fluctuating reproductive hormones, that those rates are high. And then really, if this is the menopause, then it still takes some time to come down and to be more similar to those we see in men. I want to point out that, across this period, we can see around the menstrual cycle, just menstrual fluctuations of psychiatric symptoms in about 15% of menstruating individuals. For perinatal individuals, about 25% of individuals will have significant perinatal mood symptoms. And then around the menopausal transition, we see about 45 to 68% of females having significant mood symptoms in the menopausal transition. Two other points I wanted to make on this slide were these two bullets down here. I want to call your attention that, women may have some extra mood symptoms that are related to their hormones, but you have to understand that suicide is the leading cause of pregnancy-related death in the United States, in the first postpartum year. And if you're over 50, like me, or in this range, 45 to 54, women our age have the highest rate of suicide compared to any age range or sex. So the implications of this are really, really critical for health. This is one of my busiest slides. I was going to break it into two and I didn't, so just bear with me. And this is, again, I want to start at a high level lifespan, and then we're going to dive into perinatal. So I'm a biological psychiatrist. I was trained as a neuroscientist and then went into medical school and really have focused on human subjects as my focus of working with women that I treat clinically. And so I'm aware that it's not just the biology, but that's where I study. So I wanted to give a bigger lens that, yes, there are many things that are really contributing to this increased prevalence rate of depression in women. And those can be increased rates of trauma, poverty, increased rates of work and family responsibilities, societal expectations, increased number of adverse childhood events or negative lifetime experiences, unequal power and status, but also, as a psychiatrist, cognitive vulnerabilities or the way we're sort of wired to think, and also emotion-focused coping styles are certain vulnerabilities or risk factors that are likely part of this increased prevalence. But authors, and this review article here at the bottom is a really nice broad lens approach of looking at, the authors concluded that, but going across cultures globally, those things are very different culture to culture. But despite that, we still see these really big differences and sex differences of depression. So they concluded that there really must be biological influences that are really driving these differences. And what I'm going to talk to you about today is a hypothesis that there's an underlying brain sensitivity to fluctuations in reproductive steroid hormones, so estradiol and progesterone, or some of their metabolites, so those are called neurosteroids. And I'm going to talk to you a lot about that because that is what the medications are, that they're believed to really be a driver of this across the lifespan, but in slightly different ways, whether it's around the menstrual cycle, the perinatal period, or perimenopausal period. And so now we're going to dive into perinatal. So let's talk at impact, and then we're going to dive into some biology, and then I'm going to bring it to the patient and to the development of our medications. I'm going to kind of give you some scientific premise. First of all, why we need to do this work, why it's impactful, and then the scientific premise for why we even experimentally infused women with this neurosteroid for 60 hours. How did we get there? So perinatal mental health disorders encompass a really wide range of psychiatric illness: depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, bipolar. So the stats are about 1 in 7 perinatal individuals. And then one of the most common complications of pregnancy. You might think it would be diabetes or hypertension or other disorders, but mental health conditions are one of the leading complications. And then I updated the CDC data for live births in the US for 2023 as the latest data. So on average, that would be at least 500,000 individuals in the US would have a mental disorder during this time. We know the rates are higher in adolescents, the disabled, our military veterans, and those marginalized by racism and socioeconomic disadvantage. And we know that in the US, I actually started with this, that mental health conditions are the leading cause of pregnancy-related death in the United States, followed by hemorrhage and then some more cardiac conditions. And the reason why women are dying is by suicide and overdose. And when you look at the psychiatric diagnoses of those women who have taken their lives or overdosed, it's due to a psychiatric diagnosis of major depressive disorder or bipolar disorder, plus or minus a substance use disorder, okay? Now, Indiana, this is my first time in Indiana. Thank you so much for the invitation. I looked up, Indiana has data on the Maternal Morbidity Review Committee for Indiana. And their top 3 causes for pregnancy-related deaths, and this is the data from 2018 to 2021, they're flipped and actually mirror what our data is like in New York State, where I come from. And so cardiovascular and hemorrhage are leading, and then tied for third, like it's a race, right, are amniotic fluid embolism and mental health conditions at 11% each. What's really neat about the data that Indiana collects is that they also look at contributing factors to pregnancy-related death in the state of Indiana. And they measure, well, did substance use disorder or mental health disorders, obesity or discrimination contribute to any of the reasons for pregnancy-related death? And actually, substance use disorders were a contributing factor in 48%, and in mental health disorders contributed to 56% of all the pregnancy-related deaths. So even though a new postpartum mother may have died from a different complication, they're saying that even if it wasn't primarily a mental health disorder, that a mental health, like a suicide, mental health disorders contributed to that as well. So again, a lot of impact here. We should be screening. And I talk a lot and I talk fast, so I will be sipping water in between. We need to screen. Many professional organizations for decades have recommended that we screen perinatal individuals. There are numerous, the USPSTF, the American Psychiatric, Family Medicine, Pediatrics, OBGYN. Everyone recommends that we screen. And actually ACOG, the American College of OBGYN, had a massive revision of what the recommendations were for obstetrics, clinicians. And it's really, they're asking them to screen 3 times in the perinatal period to diagnose and to start treatment. It's really very, it's so encouraging because it's what we've wanted for so many years, but without the professional college behind it, it was kind of like the psychiatrists were telling the obstetricians what they should be doing. Now the college recognizes that this is so critical. But we're not doing it. And like I said, it's not that these recommendations are new, it's that we're just not there. We cannot get evidence-based medicine into clinical practice. So these are data from the National Committee for Quality Assurance in 2022. And what they looked at is what are the rates of clinics using depressive screens, validated questionnaires in pregnancy, and then what are the rates of follow-up? So how often, when there's a positive screen, is there a note in the chart that that patient was actually advised to talk with a social worker or to seek counseling or to see a psychiatrist, right? And it's not even that they're giving them treatment. It's just that there's a note in the chart that somebody noticed the positive screen and said, I think you need help. Let me see if I can help connect you, okay? Well, we're running around 8%, okay? Universal screening is the clinical expectation, and 8% of pregnant individuals are being screened for depression with a validated tool. Whether you have commercial insurance, the rates are a little bit higher for Medicaid-insured patients, and then in the postpartum period, for screening, rates is abysmal, about 8 to 13% over here, depending on the year. There's a little bit higher rate of follow-up, but again, that does not mean treatment. So I'm starting to paint a picture of there are a lot of gaps. This is common, and then we're missing people left and right, of detecting them and getting them care. So other data shows that in reality, we're probably detecting maybe a third of patients who have depression that begins either in pregnancy or postpartum, that's peripartum or perinatal depression. Only half of them are getting treatment, so we're down to 15% of all depressed peripartum individuals who actually get something, a visit with a therapist or a dose or 2 of an antidepressant. Only half of them, now we're down to 6.3, I put the numbers so I don't have to do the math on the stage, receive what we consider adequate treatment. So that's weekly psychotherapy. That's an adequate dose and duration of antidepressant, right? And that's why only 3% of perinatal individuals actually get cured of their depression. And so I won't spend a ton of time on this. Actually, for our residency program, we do a 2-hour session on the impact of untreated psychiatric illness in pregnancy and in the postpartum period. It involves really a lot of the work that you do at a whole bunch of different levels. I want to point out that we just have, again, decades of data showing the impact, especially in pregnancy. Because for those of you do more mechanistic work, this really, for the effects that we're seeing on fetal development, infant and child development, we are now, really have strong data that this is in alignment with the theory of developmental programming, right? And what is happening is that prenatal stress, that untreated or undertreated psychiatric illness during pregnancy is influencing fetal developmental trajectories. And that is, as we know now more of the biology, occurring through the placenta. It's changing serotonergic and glucocorticoid signaling in the placenta, changing basically the neurodevelopment of the fetus as a development. And we have brain imaging, we have fMRI and structural MRI in utero of the fetal brain, that when they do longitudinal studies of the fetal imaging, and then they follow those kids through childhood, you see differences in their neurodevelopment. Now, obviously, there are some genetic things, right, because there's a family history of depression. But what this is epigenetic programming at the level of the placenta. And if you look at the fMRI and structural imaging of the children that were exposed to prenatal stress, untreated psychiatric illness, versus those who were not, you see that the brain imaging findings mirror those of what we see in adolescents who are clinically depressed. It starts in the womb. And actually, this is why I became a perinatal psychiatrist. I was going to be a child psychiatrist. And then I realized I need to go to the womb to actually affect the next generation. Okay, so I want to introduce you to Abby. This is not a real patient. Please read the disclaimer at the bottom. I would never get up here and talk about a patient. So Abby's a 34-year-old. The reason why I want you to conceptualize who this woman is, because we're going to take her through the clinical trials, we're going to take her through treatment. So you're going to see what changes in her life and the impact of this science for her. 34-year-old married female, and she has a past psychiatric history of depression and anxiety. She came to our center about 8 weeks after delivering her second child. Her mood prior to pregnancy was fine. That's not always the case, because I remember depression can happen in pregnancy, or it can happen right after delivery, and that's what we study. We study the biological mechanisms in both. But this is within days of delivery. The depression just came on very suddenly. Constant sadness, crying spells, hopelessness, that she would never feel better, that this was the deepest depression she ever felt. And she knew what depression was like. She felt rock bottom. I just can't climb out of this. She felt hopeless about her ability to return to work, had severe guilt that she was letting her husband down, her baby, her toddler, everybody in her life. She just believed she was a failure. And she had guilty ruminations about this, that she was failing everyone in her life. I can't take care of anybody, I can't take care of my kids, I can't prepare a meal, I can't feed my children, I can't clean them. And her toddler understood it. The toddler was actually, Mommy, you look sad. Like, the toddler got it, okay? And that she had no connection with her baby, and she just feels that she's letting everyone down. We often see sleep disturbances. It takes hours to fall asleep. The patients, once they get up to, care for their newborn in the middle of the night, can't fall back asleep. She was so zapped of energy, she stopped brushing her teeth and was only showering once a week with assistance. This is clinical depression of a moderate severe ability. So these are the patients that I see in my center. She lost interest in everything. She stopped her hobbies. The baby's crying actually becomes overwhelming for these patients. She had stopped eating, and she had lost 10 pounds from her pre-pregnancy weight. And many of the women will, just survive on coffee with cream and sugar, and they're breastfeeding, and they're trying. So the nutritional, right, of that, what they're doing, and then what they're being able to provide their baby. She stated, "It's exhausting to live like this. I don't know how much longer I can fight this." So what I want you to understand is that whatever preconception or you had of what postpartum depression looks like, this is what postpartum depression is. It's not baby blues. Baby blues is not, have you heard of baby blues? Yeah? Yeah. So that's not clinical depression. It's not a psychiatric diagnosis. It's experienced by about 80% of perinatal individuals as they transition to the postpartum period. Think of it as a brain reset, and you're going to understand what's really going on by the time we get further in the talk. But the moods can fluctuate, but there's never impaired functioning, and the symptoms go away in 2 weeks, so it's not that. So what can we do? We can do a lot for patients, and for decades, what we've been doing before these FDA-approved medications was talk therapy and serotonergic antidepressants. And what I can say is that we have really great randomized control trial or RCT level data that talk therapies do work. And we have a variety of different techniques for mild or more moderate. When it gets moderate to severe, we typically use an antidepressant as well. The therapy typically isn't enough. It's very hard for someone like Abby to engage in weekly psychotherapy and groups. And I mean, she could hardly get out of bed, right? So we do combination treatments. For the serotonergic antidepressants, I'm talking about the serotonin reuptake inhibitors, so SSRIs, SNRIs that are commonly used. Originally developed for major depressive disorder across the lifespan in men and women, but used in postpartum patients. A recent Cochrane database review, systematic review and meta-analysis concluded that there may be a benefit of these antidepressants over placebo in the response. So it's a response rate about 55%. So we typically have to do everything. Therapies, education, we have to support the family with whatever we can. The challenges with the medications that we've had to date are really, they take a long time. They take several weeks, 6 to 8 weeks for an initial improvement, for them to start, that we can actually measure with a scale that they're starting to get better. But usually patients themselves do not feel better until many, many more weeks. And they have to be prescribed for many, many months and sometimes years in some patients. So I work with a patient population that, there are women who decide they'd like to breastfeed, and for them, they won't talk to you about an antidepressant until they're done breastfeeding. So they'll stay depressed. And according to the journal article that was in the American Academy of Pediatrics, untreated, this can last 3 years. Women keep thinking it's going to go away, and so they don't seek treatment. Oh, it's my hormones. I'm like, yes, it's your hormones. But it's not just that. It needs treatment. Right? I'm a behavioral endocrinologist, so I like it. Yes, the hormones are super important, but just don't think that once you start cycling again, the depression's going to go away, okay? So we have low rates of response. We have a lot of side effects. So for women, they have a different side effect profile than men. And so they have weight gain, sexual dysfunction, insomnia, GI disturbances, and emotional blunting. Who wants to sign up for that? You're already depressed. You have a newborn at home. You're not functioning well, and then we're saying, I want you to start a serotonergic antidepressant, and this is how you're going to feel. So we've got to do better. So now I'm going to tell you about what we're doing better. So I'm going to tell you a bit of a story, and it's 80 years of science that led to these discoveries. I'm going to do it in 2 slides in 2 minutes. So hold on to your seats. So while the precise mechanism of perinatal depression, we don't know the answers. I don't have all the answers. There are many theories that are under investigation, and they're in very different disciplines of science. As you can see, there are genetic risk factors, epigenetic, and I can't see from this corner, so I'm going to look at my slide. I apologize. But we have, the monoamines, that really have been the mainstay of our treatment to date. We thought this is all that would work because no one ever looked sort of beyond these monoamines, serotonin, norepinephrine. I'm going to talk to you of things that are going to be in this oval. But also, I mean, there's tremendous, like decades of data on stress hyperactivity of the hypothalamic pituitary adrenal axis. We know there are changes in neuroplasticity. Inflammation is a whole field of its own. I probably should have become a inflammation researcher because it's just phenomenal. It just was never my strength. Endocrine was always my thing. But it's all of these things and not just one. So, and that's the same for major depressive disorder outside of the peripartum period. But what we think is a trigger for clinical depression is when the hormones are changing. And so that's going to lead my discussion on GABA, neurosteroids, and I'm not going to I'll talk to you a little bit about circuits. If you come to the seminar, I'm going to talk a lot about circuits tomorrow. So the leading hypothesis, so I'm going to leave you with the hypothesis, then I'm going to tell you a little bit about the supporting scientific premise for that. I'm going to repeat that hypothesis because that's what we had going into the trials. And you can decide if it was enough data to go on or not. But the hypothesis is that for individuals susceptible to developing clinical depression, either in pregnancy when the hormones are high or in the postpartum periods when the hormones drop low, is that for whatever reason they have a higher sensitivity to stress, and it is uncovered when the hormones are doing these natural fluctuations. And animal models suggest that that sensitivity is a problem between the brain steroid, neurosteroid allopregnanolone binding to its GABA-A receptor in the HPA axis, the hypothalamic pituitary adrenal. Just think of like the seat of the brain that allows you to control stress, right? To adapt to stress. So that is what we're going to discuss. So don't freak out. You've got like 3 or 4 biology slides, and then we're going to go into the clinical. But I just wanted to give you some background of what it takes, what investment it takes in science to actually get to a therapeutic that's going to help human health. And we all have a role, depending on what discipline you're in. So we're going to start with some definitions because I'm talking about steroids, and I'm not telling you what they are. Neuroactive steroids are steroids, and they act on the brain. They either work on transcription factors, and so they regulate gene expression. Those are sort of longer term effects, so we're not going to talk about those today. Or they interact with neurotransmitter receptors in the brain. That's what I'm going to talk to you about today, because what we're seeing are rapid effects, rapid antidepressant effects. So we know this is probably not going through gene transcription or gene expression changes. And neuroactive steroids, they're made in the brain. This is a picture of an astrocyte, so this is a cell type in the brain, and they're made in other cell types of the brain as well. But they're also made in the ovaries, the adrenal glands. The placenta makes a ton of neurosteroids during pregnancy, and they're made in the testes. I just learned a couple days ago that the eye, the retina, has its own steroid producing system in the eye. And so these steroids are really important. They're serving many different functions all over the body. And if I can show you just this figure, so, they all start from cholesterol. These steroids are made from cholesterol, and then they go through this pathway, and they're here you go to pregnenolone, to progesterone, to allopregnanolone. I'm going to talk to you about allopregnanolone. That's the medicine that we injected, in a 60-hour infusion that we put into postpartum depressed women. And it interacts with the GABA-A receptor. GABA is the main inhibitory neurochemical of the brain. There's a whole nother side to this, the left, and I'm not going to say a word about it. You can ask me questions, and I'm not going to know much because no one studied it. Dr. Didak and I are going to study it. We're going to study it with spectroscopy. But no one has bothered to look at what estradiol's doing. It seems like both hormones would be important. And so I'm going to tell you about this. But what's important is that this steroid is made in the brain. It has to bind this receptor. And there are very specialized receptors that can only communicate with these neurosteroids. And those are really critical because we think that that's part of the pathophysiology of the disease. And all of this apparatus is in that special brain region that controls stress. So you need neurosteroids to be working correctly under acute stress conditions, studying for an exam, or prolonged stress. Maybe you're in an abusive relationship, okay? 80 years, 2 slides. Discovered in 1938 from adrenal glands. And then there was a term made, we didn't know if it was made in the brain, it was in the brain, but did it come from the periphery? Actually, it's both. It's made in the brain, it's made in the periphery, and what's in the periphery goes to the brain. It passes the blood-brain barrier. I told you the definition that was by Bob Purdue and Steve Paul from 1992. And then we were actually able to measure these things with an evolution in technology of using gas chromatography and mass spectrometry to actually measure all those different steroids that sometimes are just a little functional group different than each other. We needed that type of method to drive the field forward. We had used immunoassays in them before, and it's really hard to use immunoassays to do this work. And then there's a lot of work in stress, looking at prenatal or at preclinical models of stress. Depression is a stress disorder. And so then in the 2000s, people said, well, what's happening during pregnancy when these neurosteroids are changing? Well, as I've said, neurosteroids are high during pregnancy. They crash in the postpartum period. Now we could measure them. And the hormone levels in the brain, the steroid levels in the brain, are actually changing the neuroplasticity of the maternal brain across pregnancy and the postpartum period. So that neurosteroid level, allopregnanolone, is actually driving changes in the receptor it binds. It is down-regulating it. If you get snowed with allopregnanolone, now it takes several months to get really high levels of allopregnanolone during pregnancy from the placenta, but your brain has many months to adapt to it. If you did not down-regulate your GABA-A receptors, you'd fall asleep. You'd sleep for your pregnancy because allopregnanolone is sedating. It's working through your GABA receptor. It's also affecting GABA concentrations, and then more research started linking that actually you could rescue stressed animals by using allopregnanolone. And then the thought was like, is it an antidepressant? So in summary, under stress conditions, when the brain does not adapt, we think a lot of this is GABAergic, so the inhibitory side, there's excitation and inhibition. But failure of the brain's receptors, the concentrations, the neural connections, if that does not happen as it should, either in pregnancy when the steroids are high, or after delivery when the steroids are low, again, all those receptors and concentrations and circuits have to adapt, that's when we see the symptoms of depression. Psychiatric disorders are neurocircuit disorders. And so this is the background I wanted to give you as we talk about why would you inject a patient for 60 hours with a neurosteroid. So this is my colleague, Samantha Meltzer-Brody. She's the chair at the University of North Carolina, now an executive dean at the School of Medicine there. And we've worked together since about even earlier than 2015. But she really led the breakthrough proof of concept study of what would happen if we took 4 women like Abby and we gave them pregnancy-sized doses of allopregnanolone in 60 hours. I just told you it takes 8 months to get to those levels in the brain. Your brain needs time to adapt. We're just going to give them a shot, big infusion of allopregnanolone. Everybody got 60 hours. We ramped them up. She ramped them up. And then they had several hours at the full dose and ramped them down. This is the molecule. It was what we make in our ovaries and our brain is identical to what we gave them. It's just a synthetic version. Really quick, we don't need stats for this, right? These are the 4 women. This is their depression before the infusion. This is their depression after. If your score is less than 7, you're no longer clinically depressed. It's eye-opening. Our drugs don't work like this. I've been a psychiatrist for 18 years. I mean, I trained on the ketamine studies at NIMH. I saw rapid-acting antidepressant actions before. I've never seen it with a neurosteroid or in a postpartum depressed woman. So this data was enough to say we need to do clinical trials with a placebo. And that's where I started doing the trials and have done all of the subsequent work in this space with Dr. Meltzer-Brody and others. So we did a series of phase 2 and 3 studies. Again, 60 hours of either 2 doses versus a placebo. We shut the pump off at hour 60, and then we see how they do. And so here we see a large drug response. This is in blue. We also see a large placebo response. If you have questions on that, I can tell you. We see a really large placebo response in depression clinical trials. But the drug effect was 4.2 points. Or more, 4.2 points. In antidepressant trials for major depression, it's usually 1.8. That's how much the drugs beat out placebo for all the medicines that are currently FDA approved. So this was double what we expected. Side effects, I told you, too much GABA, too much allopregnanolone, sedation, right? It's a sedating medication, it's binding GABA. Excessive sedation was our top one, and actually a percentage of women lost consciousness, they fell asleep. And so because of this, the medication could only be prescribed at certain facilities under very special sort of safety, like checking on sedation every 2 hours to make sure that the dose wasn't too much for an individual. And then data that we did later showed that there's very low passage into the breast milk, because that's really important for this patient population. So this is, I want you to think of Abby again. She enrolled in one of our brexanolone trials that I was leading. And, for some women, I don't know if you can get it, but the improvement is so fast, it's really hard to wrap your mind around. And so I'm just going to tell you a brief vignette. I get goosebumps usually when I think about this patient, these patients. And because we had nothing to offer these women that would work like this, right? The serotonergic antidepressants, they work through growing new neurons and neuroplasticity, and they just take time. And so I had started Abby's infusion the day prior, and I came onto the unit, and the nurses were coming down like, Dr. D, I have a long last name, it's hard to pronounce. Dr. Didek does a beautiful job pronouncing it, but a lot of the nurses was like, everyone in the hospital calls me Dr. D. And Dr. D, it's your patient. And I'm thinking, oh no, like this is not the news I want first thing coming onto the unit, right? I'm like, what is wrong? And they're like, what did you give her? And I'm like, what? They're like, what did you give her? She's in her room right now, smiling from ear to ear, watching a morning show on the TV. And it's like she woke up a whole new person. And I'm like, what? And so I go in and I see her. And it's true. She was completely different. She went from being emotionless, sad, hopeless, and having passive suicidal ideation to telling me that when she woke up, the weight of the depression just wasn't there anymore. The guilty thoughts were gone. The suicidal thoughts were gone. It just wasn't there. And you're like, how? Why? It didn't make sense. So later that day, her husband came in with the children, the baby and the toddler. Her mom came in. And the mom, who really had effect on me, and this is before I had kids, so, she came in and she's like, what did you give my daughter? And she said, thank you. She says, we have our daughter back. And I get emotional because I'm a physician and I'm doing this to help women, right? But to see this was unbelievable at the time. And it's still, so many years later, hard to believe. So the FDA approved the medication in 2019. These are our 2 Lancet publications that went towards that. So we're good, right? No, I still have time. We're not done. So brexanolone was a breakthrough for so many reasons, right? Now we had a first-in-class antidepressant that worked faster than anything we knew. It was naturally made by the brain, okay? And it really changed what we thought was possible. But it was inpatient, right? We were separating families. It was expensive to come into the hospital. We had all the safety things which needed to be done. And the logistics were really, this was not going to get to people who needed it, right? So the company who created the synthetic version, the brexanolone, developed an oral neurosteroid, zuranolone. And as you can see, they're almost identical, but they're not. So it's an analog. It has this cyanopyrazole ring at the back. But the thing is that it can be taken for 14 nights at home. It's non-inpatient. It's taken in the home. So then I led these studies, these clinical trials, and again, women like Abby with severe postpartum depression, and they received a 14-day dose. They took it every night around 8 p.m. at home. Or placebo, and we saw what depression did at day 15, and you see the exact same thing, 4-point difference, 4.2 difference, drug effect. So really similar drug effect, just different time scale because it's got to go through the body to get to the brain, where when I gave it as an infusion, it goes directly to the brain. There's no past go, no past the liver, it's going directly to the brain. And so, and response rates were about 72%. So again, that was, looking good. Now, this was the first study. Then we did it again at 50 milligrams. The FDA wanted to do it at another dose. Often they want to have a dose range for people and not just try one dose, even though it worked. Because I was like, but it works. Why do we need to give them more? So we did the exact same study, but at 50 milligrams, same outcome measures. We saw the exact same data. And so again, you see a rapid drug effect. You also see the placebo effect. And what's different here is that we statistically powered the study so that we could actually look at day 3. So remember, it's a 14-day course. It's not to be repeated. It's only 14 days, and then you're done. You don't do it again. You just do a 14-day course, and then if there's more that's needed, you do all the other things that we do as psychiatrists and psychologists. But now we could say, because this was a key secondary outcome measure, that after 2 doses, we saw statistical and clinical difference in the patients who got the medication versus placebo. So response and remission rates, these were a little bit lower for this trial. This was 57% in the zuranolone group versus placebo, and this also got FDA approval. So this was fall 2023, and if you think that this neuroscience major from UMass Amherst as an undergrad doing rodent, circadian rhythm research, ever thought she was going to be a part of 2 FDA approvals in her lifetime. I mean, I had big ambitions, right? This does not occur in most of our lives. This is just, like I said, transformational for me as a physician scientist, as a mother, as a woman, and I think has to be empowering for all of us that do women's health research. These studies made global news. There's a reason why I did 100 interviews in 7 years. I'm going to trip over this red wire. Red is usually not good. And for good reason. It was really, these were breakthroughs. Side effect profile, it's still a GABAergic medicine. There's still sedation, and 36% are having sedation. So we do have to monitor that. We can drop the dose. There's a boxed warning. Before women were in the hospital, so they weren't driving. But now, because it's 14 days, 12 hours after, we just say no driving. You can't go out for diapers at 2 a.m. You've got to, hunker down for the night. So we don't know how it's going to affect your driving ability. And then again, this is a postpartum treatment. That's the kicker. We can't give this for the patients who are depressed in pregnancy. And so it's like, we can do what we can do, but if there's still no better, then we can give it, but we have to wait till after delivery. And at least data that we've just done from breastfeeding, it looks, again, very low expressions, lower than our typical antidepressants in breast milk. So how are we now? I'm actually doing okay on time too, so we'll have time for Q&A. I'm not done. I don't know, I'm not going to retire, right? So I want to go back. So we're doing all the clinical trials, right? And that, like you said, it's over a decade, right, to do all this work. But I was NIH funded. I had R01s, I had other studies, we were doing other stuff, and science was progressing while we're doing all these trials. So I want to bring you up to speed of where the science is, because that's the next step. That's the next step for Dr. Didek's lab, for my lab to work together. And so I put MOD, that's mechanism of disease. I talked a lot about that, right? It's allopregnanolone and the GABA-A receptor. And what the research really has progressed, and this is a colleague of mine, Jamie McGuire at Tufts University. She's a basic neuroscientist. She's done so much pivotal work in the GABA knockout mice and all of that in this field that has just really put together the scientific premise for going here. That what her lab is showing is that these naturally made endogenous neurosteroids are setting an effective tone in the brain, and that when those she uses rodent models, are subjected to chronic stress, that signaling cascade, how I showed you all those steroids start breaking down into other ones, that's disrupted. The enzymes aren't working. So stress somehow is impairing that metabolism. That is disrupting the brain networks. And so because it's affecting GABA, again, you need a balance of excitation and inhibition across the neural circuits so that your circuits are communicating as they should. If that imbalance is there, they're not communicating. She sees this in her rodents. Then, where my piece has been, and I've just put like 15 years of NIH-funded research in one sentence. That's dangerous to do because it feels like that's all I've done in 15 years. But we've had a lot of research. So the focus of my work is in women, is in human subjects. And so what I've done using mass spec, using spectroscopy, imaging, a whole bunch of different techniques, is that we see the same steroid deficits in our postpartum and peripartum depressed individuals. And then when you look at the brain, we're seeing very similar perturbations of the neurocircuit and structure in our depressed women. And that one sentence just encapsulated like a whole bunch of grants. But then my question is, why does it work? Is anybody asking, why does it work? Why would you give 60 hours, like this big bolus of allopregnanolone? What is it doing to the brain circuit? I don't have the answer, but we will. Our grant's funded. We're going to get that answer and answer that question. But from my colleague, Dr. McGuire, in her lab, what she's done is she's done all the beautiful rodent work where she stresses, the rodents, and then she sees all the deficits and she puts, zuranolone in their chow. And then all of a sudden, the steroid levels go normal, the circuit goes back to functioning, and the rodents are no longer showing depressive symptoms. And so what she's able to discern is that these medications are acting through those sensitive subtypes of GABA-A receptors to reset the circuit, to shift it out of its depressed circuitry to a healthier one that is stable. And then when she stops putting zuranolone in the chow, it doesn't matter because they don't need it anymore. And so that is what we've got to figure out, what is happening in our patients. So really this is the next step of what we work. I think I have like 3 slides left, so I think we're okay on time. Not everybody gets better. And that bothers me. But it's because the brain is so complicated, we have so many different phenotypes of depression, that not everybody is going to probably have this neurosteroid deficit. Even the ones that are having a clinical depression, they may have more of an inflammatory depression, or they may have more of a different subtype, right, of depression that may respond more to neurostimulation or a serotonergic. And right now, there's no precision in psychiatry. It is, you try the first thing, and if that doesn't work, you try something else. And if that doesn't work, you try something else. And I always thought it was just, okay, in psychiatry, we really don't understand the brain like we need to, right? And in neuroscience, like we have a lot to learn. But I'm also finding out, that this exists in other fields too. In autoimmune diseases, you try one biologic. If that doesn't work, you try another biologic that's focused on another anti-inflammatory. There's not phenotyping or precision for autoimmune diseases in many cases, especially in GI. So we're all trying to get there, but my point is that great that 57% of people had the response that Abby did, but 43% didn't. They may have been 40% better, which I'll take, because if I have a suicidal postpartum mother who's at home with her baby and she wants to die and she's thinking of walking across the train tracks in New York, if I can get her 40% better in 2 days, I'm going to take it, because then I can do all the other things that I can do for her, the psychotherapy, the serotonergic antidepressants, the peer support, the family support, all of that. Get a visiting nurse in the home. But we got to do better. We got to do better. And so really what our next steps are and where my work is going is precision psychiatry. So how do we identify when all these, I couldn't find a figure that had, it was a busy figure, I'm sorry, and you don't need to read all the words, but our population that we treat is very diverse in their clinical phenotype. And we know that not everybody is going to respond, and right now it's trial by error. So by finding out and being able to see what is going to work for different subsets, then you just give them what they need and they get better. And so my last 2 slides are that what I've been tasked to tell you in 40 minutes about neurosteroids and GABA and the pathophysiology of perinatal depression, the development of novel therapeutics, 80 years of research, is a lie. No. it's not the whole story. And so as we know, the brain is way more complicated. It's not just GABA and neurosteroids. As a scientist, I have to focus on the details, right? We can't study everything. But the reality is that these neurosteroids modulate many signaling systems outside of GABA. And we have no idea if they're part of the antidepressant effect because it's never been studied. I could put money, I'm not a gambling woman. I don't either buy the tickets, the scratch, I don't even do that. So I'm not a gambling woman, but I'm going to put my bet on inflammation, cellular stress. These neurosteroids are neuroprotectant. And so there's a reason why the fetal brain is bathed in allopregnanolone during delivery. It's to protect the fetal brain from seizing as it goes through the birth canal. They have massive anticonvulsant effects, anxiolytic effects, and sedative effects, and neuroprotection. So there's a lot more going on, both from the periphery and from what's made in the brain, and there's a lot more that's happening. And it's not an area of my research, but I'm going to have to collaborate to be able to put this together. But my point is, because neurosteroids have these pleiotropic effects, it's no longer a discussion about postpartum depression anymore. These are all the disease states now that neuroactive steroids, either in preclinical research or in therapeutics, are being examined for their role in these diseases. So things like tic disorders, multiple sclerosis, Alzheimer's disease, TBI, traumatic brain injury, stroke, glaucoma. I read about the eye the other day. There's neurosteroids in the retina. Glaucoma, HIV, epilepsies. A lot of this work actually started with epilepsies. So the impact, funding, a little K23 and an R01, and some neuroscientist was told, Kristina, pick a real psychiatric diagnosis to study. You should study schizophrenia. No, I want to study postpartum depression. Do you want to be known for studying postpartum depression? That's one of my male mentors that wanted to tell me that. But we're not funding enough. And this is not to say that psychiatric illness in women is more important to study than any other thing. It's just that this is not equal footing. $53 million in 2017, CDC and NIH funding went to perinatal mood and anxiety disorders. I myself got a big piece of that. Is there no one else doing this work? And I got to fight my rear off to get those dollars, right? We've got to work hard because of the funding disparities in mental health versus other medical conditions. And so I had the honor and privilege of presenting. I was asked to speak at the National Academies last year because Congress asked the National Academies, they appointed them to convene a committee of experts to assess the state of women's health research at NIH, identify critical knowledge gaps, assess the level of funding for women's health research, and more. And so they had experts from all over the country come to speak to this committee, and I spoke on what those gaps were for perinatal mood and anxiety disorders. Colleagues of mine spoke around menstrual cycle and menopause, and they had everybody there. And there's this amazing consensus study report that was just published in December 2024, and it's a bit of a read, but for anybody, and it's hundreds of pages, it takes a very strong stance of what needs to change if women's health research will ever have parity with other forms of research in the United States. And so for anyone doing women's health research, I implore you to take a look at that. And I'm done. I'm going to thank my funders. I'm going to thank my collaborators, especially the DIDAC lab here at Purdue, my team in New York, and my collaborators across the country. Thank you so much for your attention.